Hello, I'm Dr. Randall Secreest, your host for eOrthopodTV. Today we'll be talking remotely once again with Dr. William Seeds. Dr. Seeds is an orthopedic surgeon in Ashtabula, Ohio. Dr. Seeds is also the sports medicine provider for the Great Center in Geneva, Ohio. Thanks for joining us today, Dr. Seeds.
Randy, thanks for having me.
Well, Dr. Seeds, today I thought what we would discuss is a problem of the foot, specifically a problem of the big toe and the joint between the toe and the foot that we call the first metatarsophalangeal joint. But the condition I thought we would discuss is called Hallux Rigidus. So if you would, start out by just explaining what that strange word or those two strange words mean.
Well, Hallux rigidus is referring to that joint, the big toe between the what we would call it's the biggest part of the joint on the ball of the foot between what we would call the proximal phalanx and the metatarsal. So it's that first joint, the ball joint of the first digit, the great toe, and usually what that's referring to is that rigidus aspect is that they're losing motion in that joint, so they're getting stiffer, and with that stiffness comes pain. And typically the people that I see with this problem are people that can tell you that they've slowly been having difficulty with range of motion of that joint and with increasing pain with activity. And it's almost like a very slow degenerative, an arthritic condition of that joint that happens over repetitive type of trauma. It could have been something where they've been very active in sports when they were younger and had a lot of injuries, traumas to that joint itself, and over time it develops. Or I tend to see it in a lot of construction workers that use their shoes and boots to kick a lot of things in their work environment, where over time and just the fact that they're on their feet all the time and how they use their feet, they tend to have these problems over time. So it's actually a common problem that I see quite often, where they're just not sure how it's come about. They can't relate it to something specifically, but it's happened over time, and then we basically will look at it and make some decisions on treatment.
I think we probably ought to clarify a couple of concepts that you've just gone over. And I think you mentioned that Hallux rigidus is an arthritic process that involves this first MTP joint. And when we use the term arthritis, I think for you and I, we tend to lump that term and use it to describe a lot of different conditions. But we probably ought to point out to patients that there's an arthritis type problem that occurs all over the body, such as rheumatoid arthritis or some of the arthritises that we get in a systemic way that involve literally all the joints. And that's probably a little different process than the arthritis, or maybe even more correctly, the arthrosis that occurs in a joint just because it wears out, or because it wears out prematurely because the joint's been injured. Now, and I think we sometimes refer to that type of process of arthritis as an osteoarthritis, or in some cases we actually call it a different name, arthrosis, to suggest that it's a wearing away process. I think what you've just described in terms of Hallux rigidus, though, with the construction workers, people overusing this, sports people using their toes and injuring the toes over and over again, my understanding is what we're really talking about when we're talking about Hallux rigidus is usually an osteoarthritic process, or an arthritis that has come from wear and tear, either from repetitive trauma or a serious injury to that joint in the past. Is that the way you conceive of Hallux rigidus?
Yes, Randy, that's a very nice way of going through the scenarios of understanding arthritis in simple terms, and that's exactly right. That's exactly how I see it.
Well, I think the other question you need to ask is why this joint? Do you think that we're more prone to injure this joint? Why does it happen in this joint and it doesn't happen in the other toes or other areas of the body like this?
Well, it has to do with the mechanics and the demand of that first metatarsal phalangeal joint, and the fact that it's bearing a lot more load force through that joint than the other metatarsal phalangeal joints of the foot. And for obvious reasons, it's the bigger boned joint, and it's going to be dealing with a lot more stress through the foot. So that's through the ankle and the foot, and that's in any type of kicking motion, any type of sporting activity, that's where the basis of the mechanics are from, that first metatarsal phalangeal joint.
Well, let's talk a little bit about the symptoms. You had mentioned that rigidus means stiffness. So one of the first things that people notice is the joint's getting a little stiffer, but it's also hurting. What other symptoms should patients look for to realize that perhaps this is a problem that they're going to need some attention for?
Well, some people will definitely the stiffness issue is something that occurs and progresses over time. Initially, they'll feel some stiffness and so forth, maybe at the end of the day or early in the morning. It'll go away after activity and get a little bit better, but it's something that kind of comes and goes, and then progresses on. The other symptom is swelling of the joint, and where they'll start to, with that stiffness, they get swelling from a little bit of fluid because of the breakdown of the cartilage in the joint that occurs with this, and also over time they'll get to where they feel like a protuberance or what they may call a deformity or a bone spur, if you want to call it that, where they'll feel a difference in the anatomy over the top of that joint, and that's of concern to them. They'll actually see this joint potentially grow in size. Some patients will describe a numbness that they start to feel within the great toe, and sometimes the second toe, which will happen, and of course the pain aspect that comes with it. So it's kind of a modulation of those activities together that kind of present themselves at different stages. But initially, most of them will tell you that they've had it for a while and they've been able to live with it and work with it. And some of them will even tell you to the extent of where they've changed shoes and found that a harder sole shoe sometimes works better than a soft tennis shoe. And that just has to do with the mechanics, again, of that joint, where they don't have to put as much pressure on that first metatarsal joint, phalangeal joint, as much as they would in a tennis shoe.
Now, when you see these patients for the first time in your office, they've obviously gotten to the point to where it's bothering them enough to seek out some specialty care. How are you going to evaluate that patient?
Number one, I get x-rays on all of these patients to look to see if we start to see changes of the joint itself, to see if we see any of the, it's just number one, to see if we see a breakdown of the joint. Number two, to see if we see any of the bone spurring, as I said, that you can see on the top of the joint itself, to get an idea of the progression of it, and then of course the physical exam, and to look and compare it to the opposite foot. If usually you've got something else you can look at and you can compare that range of motion to the other foot, and then we go from there as far as how long it's been. How long has this been a problem? What have you done to treat it? Initially on all of these, I will initiate a conservative approach of trying an anti-inflammatory to try to treat the joint itself, and then I may recommend some type of either where they can get an insert, a hard type of insert that can protect that metatarsal joint, where they're not having to push off as hard and they can wear in their shoe, or trying to convert to more of a rocker bottom type of, to the severity of the disease, where if it's really severe and you're trying to cool it down, you can get to where you can get them in a rocker bottom type of sole that can make a big difference in the weight bearing. Or I might even totally immobilize these, where I put them in like a cam walk or a cast boot for 2 to 4 to 6 week time frame, just to cool the joint down, and then see where we go from there. Because sometimes all it takes is taking some stress off that joint and then backing up from there and treating the inflammation, and you could get some of these people doing pretty well.
You know, it's interesting that you mentioned the rocker bottom sole shoes because, you know, 20 years ago, 15 years ago, even 10 years ago, you usually had to get shoes like that made special at some sort of an orthotic shop, or maybe you could have them made at a very good shoe store. But now, you know, people are selling retail rocker bottom shoes and recommending them for just normal wear. Do you find that these shoes are applicable to this disorder? Do you recommend these shoes for patients that have Hallux rigidus?
Yeah, absolutely, Randy. I think they make a huge difference. Patients can tell me right away that they can do more than they've ever been able to do. I mean, they can become active again. They can walk the mall. They can walk, because a lot of these patients will tell you how they have to restrict their activity, or they just can't walk distances anymore, or they can't be on that hard surface. And all it takes is that changing that weight-bearing aspect of going to a rocker bottom shoe, and you've corrected everything. And that's what you've described in making that more available now with just typical training shoes. I mean, they have training shoes now in sports that are sports specific that work with these. They have them for you know, for just daily activity. They have them where they have the reverse rocker bottom on both sides now, like Skechers is made, that's supposed to, you know, not only work on the front of the foot but also the Achilles and stretching the Achilles. So it's amazing to see where these shoes have gone, because it's readily available, as you've said, and it makes just a tremendous difference right away, where the patients are comfortable wearing them because other people are wearing them. It's not a fashion statement. It's actually an in shoe now. So it's kind of a neat thing where you're able to treat something pretty quickly like that.
Well, and I think the other thing is it's probably a lot cheaper for patients. You know, 10 years ago when you had to send someone to an orthotic shop, they would have to take a pair of shoes that they liked, have them completely redone, and it was not a cheap endeavor. It generally cost several $100s to have a pair of shoes made. And of course, you know, that's just one pair of shoes. So if you've got 3 or 4 pair of shoes you like to wear, then you were sort of stuck, and it could get to be a very expensive endeavor. So I think the other thing we ought to explain to patients is why these rocker bottom shoes work. You know, the mechanics of what it really does to relieve that first MTP joint. So can you explain that to us?
Sure, Randy. What it's doing is it's doing the work for where you have to do the toe off. When you're walking, there's heel strike, and then the foot rolls, and then there's toe off as your foot comes off the ground. Well, what that rocker bottom is doing is it's already creating that roll where they don't have to toe off because the shoe does it for you. So it's taking that stress off of moving the joint, and it makes a tremendous difference in that load across the joint with every step you take. So you're reducing that load, you're taking the stress off the joint, and you're not fatiguing the joint. It's doing the work for you.
Well, in terms of treatment, do you find that you use cortisone injections in the joint very much to try to calm down this condition?
Yes, I will use cortisone injections depending on the stage of the disease. You know, if I get somebody, like, for instance, let's say I get one of my construction workers who's really inflamed, and they need to keep working. They don't have the time to rest it, or they can't even put themselves in a boot, which I'd like to initially do, but they can't. I don't hesitate to inject a little bit of a steroid in that joint itself and to help with that aspect. It doesn't correct the mechanics of the joint, but it certainly helps with the pain and improving that buildup of effusion in that area. And then we can do other things to work on, you know, for those specific type of patients. We can do other things then to try to restrict that motion and work on helping them in getting them to where we can manage it conservatively.
Do you have any experience using some of the injections that we're using in other joints like the knee, the viscosupplementation? Do you see a role for that in this disease process?
Right. Well, that would be an off-label use of the material where you'd have to discuss that with the patient, where it's not it's not approved for that joint specifically, but it has been, certainly has been written about and used with some athletes and with some people in if you have that discussion, you can try that avenue. Personally, I have not done that. I have found that because of how that viscosupplementation has gone in the knee, and the fact that initially when we all used this or tried it 10 years ago and that most of the insurance companies covered it, we find now that not many insurance companies now cover that supplementation even for the knee, and it's a pretty expensive out-of-pocket cost for that patient. So you've got to make sure they understand the cost involved and so forth. But personally, I haven't had any experience with using that specifically for the great toe. Would I expect it to have some importance or improvement? I think it definitely has a place, as long as the patient understands that it is an off-label use, and you make sure that they understand that.
Well, let's move on and talk a little bit about surgery. Obviously, what we've described is conservative care, trying to put off surgery as long as possible. What drives you to recommend surgery to patients?
Surgery is I reserve for those patients that haven't responded to the injections and don't do well with the conservative measures of changing their shoe wear, or where they've gotten pretty stiff, where there's really minimal motion in that great toe, combined with pain, to where they're having significant difficulty even with when I put them in a cast boot for 4 to 6 weeks and they don't respond. Then I talk to them about the route that I take surgically in trying to correct this. Is I'll do something where I don't look at, in my practice, I don't discuss trying to fuse the joint. I want to try to keep some motion or improve the motion that they have. So I'm a believer in keeping the motion in the joint. And I do more of what's referred to as an interpositional graft, as opposed to a joint replacement, which may be another common procedure that you may hear about with that joint. I typically want to keep their joint intact without having to do any specific joint replacement. So what I'll do is, my surgical approach is usually what I'll do is what's called a double osteotomy, or a double something where I go on both sides of the joint and I'll remove just the top part of the joint, about 20% of it, and then I'll interpose the capsule into the joint to kind of act as a shock absorber in the joint, so to speak, but also to act as a spacer. And we're usually able to, what I can usually produce on the table, let's say if I can get them 60 to 70 degrees of motion, usually what they'll end up getting out of that is about half of that once it's healed and so forth, where they may have not even had 5 or 10 degrees to start with. We'll end up getting 20 or 30 degrees, where that's a significant difference for them, and that's usually the standard type of operation I use for that, and we've had very good success with it.
So let me get this straight from what you've just described. When you're talking about these double osteotomies, are you talking about taking off the bone spurs at the top of the joint, or do you realign the joint surface from the shaft? I'm not certain I understand what you're taking off.
Right. I'm sorry. It's like a cheilectomy. I'm not realigning the joint surface at all. I'm just taking off the top of that, so to speak, bone spur, and going down into the joint a little bit, of taking a little bit of that cartilage. So they're almost like, if the two bones are like this, I'm coming in from both sides in an angle of taking the bone down, and then interposing a graft there, so that I can then get an interposition that assists with recreating kind of the joint for them.
So that top area is what's bumping together, so to speak, hitting together as they pull that toe up. The two edges come together sort of like a nutcracker, and you're taking those bone spurs off.
Correct. That's part of the problem. That's correct.
Now, you had mentioned artificial joint. Is that becoming a very common treatment option for patients to actually replace this joint, similar to what we would do with the knee, the shoulder, the hip, that sort of thing?
I think it's kind of a preference of specialties and so forth. I think you see that more common in podiatry practices, where they'll do more of replacements like that. My training has been more specific in trying to keep as much as the joint as you can, and do the interposition and stay away from implants, because I think you can have more problems with that approach, obviously with an implant versus keeping the rest of your joint. And I mean, I can tell you that these operations have a very good track record with not progressing on to fusions at a very low percentage rate. So I think the work speaks for itself, is its success rate, and we've been able to stay away from, like I said, fusions and joint replacements.
And the logistics of the operation, is this an outpatient procedure, or do you keep the patient overnight?
This is an outpatient procedure also. Again, the key with this procedure is protecting the patient from doing too much too soon. I'll usually keep them in a weighted a boot that's like a cast boot to keep the weight off the front of the foot. I'll let them put do some weight bearing with crutches, or even without crutches as soon as they're comfortable, but I'll keep them in that boot for 6 weeks. During that 6-week time frame, though, I do have them working on range of motion of that joint. I'm trying to keep as much of that motion as I can, as I created on the table, and that's what they work on the first 6 weeks. And then after I feel the soft tissue and the incision is healed well, then we get them out of the boot and actually start on weight-bearing type of activities, and working with the foot and ankle all together, in improving the mechanics and strength. And we get them back to, I think, into most of the patients, I'll tell them it's usually a 12-week process of, at the end of 12 weeks, where I feel pretty comfortable getting them back to their activities.
And that's true for somebody that you mentioned, like a construction worker or maybe an athlete that is going to really abuse their feet. You think 12 weeks and they're ready to go back to that level of activity?
Yeah, some of them, Randy, take a little bit longer. They can take 4 to 6 months before they're back to, being full, where they'll tell you, I mean, they can go back to work, they'll be back, a construction worker can do his activity at 3 months, but he'll tell you it's maybe more like 4 to 6 where they're not thinking about it, and they're able to pretty much do the heavier labor that they were doing once before. But I think as far as let's say the athlete that over time that's hurt themselves, and they're they're not the high demands on the foot, except for just maybe typical home activity or work activity. Those people within 3 months have, I would say, for the most part, are back to normal. When I say back to normal, they're back to a state where they were significantly improved before, where they couldn't bend that joint and bear weight where they can now for distances.
Let's talk a little bit about the things you worry about after surgery and perhaps during surgery. What are the complications of this procedure that you're concerned with as a surgeon?
Well, the complications are certainly wound problems, the wound breaking down, and infection post-operatively. Those are things we like to keep an eye on early. The other is we want to be real careful not to create any nerve injuries as far as sensory changes of the great toe, which is something that is a potential complication that you want to be careful of. And I think those infection and wound dehiscence, or the wound opening, and the nerve injury are the bigger things that we're looking for initially.
Well, this sounds like a pretty successful operation, pretty successful treatment for a pretty irritating problem. I don't think that this is a dangerous problem in most people's eyes, but it clearly causes significant disability, because we have to walk on our feet every day. And anytime you have something that changes your gait, it's pretty hard to get around that. So I think that we've we've explained this pretty well to patients. I would ask you as we close this discussion if there's anything you think that we haven't discussed that patients should know about this disease process.
Well, I try to explain to most of the patients that if we end up going to that surgical procedure to improve the motion and the problem, I remind them that it took them a long time to get to this state where the toe is slowly progressed into a very stiff process of loss of motion. And I explained to them that we're going to be able to correct a lot of this surgically, but they've got to work very hard to keep that motion because that toe is still going to want to stiffen up. It still has those properties of that inflammation where it wants to stay stiff, and they got to work really hard those first 6 weeks to get the most they can out of that motion. And I think if you can get that point across, it makes all the difference in the world in your surgical outcome with that.
Well, and I guess like most things that we do, early motion and lots of it, and stick with your program is probably good advice. So thanks for pointing that out.
Thank you, Randy.
Enjoyed our discussion today. Look forward to further discussions in the future. So thank you very much, Dr. Seeds.
Okay, Randy, take care. We look forward to seeing you again.